Okay, I'd like to call the July Health and Human Services Committee meeting to order. I guess we're going to call Kevin first from Office of the Aging.
Okay, thank you, Supervisor. I just have one quick resolution. It's to request permission to hire one seasonal part-time bookkeeper to perform our HEAP processing for a 3-month period. HEAP stands for Home Energy Assistance Program. It's for generally a 3 to 4 month position, and it's at a cost not to exceed $6,325. This is a seasonal position that we've filled since I've been director here. These folks do is assist seniors in filling out paperwork and filing for HEAP benefits. And last year we processed over 500 of them. And with what's going on this year, we're anticipating a lot more. So, and even though it says it starts August 1st, the only reason we put that date in there is that this person has to participate in a mandatory 1-day training program, which usually occurs sometime in August. That way we can put them on the payroll, but they usually don't come back until mid-September to start actually working, processing the applications.
Kevin, this was a budgeted position?
Yes.
Are there any questions for Kevin?
No, this went through the Personnel Committee yesterday. It was approved.
Okay,
Thank you,
I'll
Matt.
make the motion. Yuri.
Second?
I will. Patsy.
Patsy, second. All in favor?
Aye.
Aye.
Opposed? So carried. Thank you, Kevin.
Thank you. Have a good day, gentlemen.
Ladies. Okay, Rob, I don't know if Bob Gibson wants to introduce the guest speakers.
Sure, Bob.
Thank you. Thank you, Mr. Chairman, and I am pleased to introduce our speakers today. They had actually come into the department last fall to begin discussions on medicine, which we didn't realize at the time was so timely. And given the events of the last 4 months, I thought it would be a very good opportunity now to essentially catch up with these folks. They've been over to the chairman's office. They've been in here. I don't know if Mr. Thompson wants to go first on the line and make introductions, but I thought we could give a sense of the ability of telemedicine to really help us through the last 4 months and the public health crisis that arose. So, Mr. Thompson, if you can hear me, I'd like to turn it over to you and then to the gentleman running the network.
Mr. Thompson? Is Mr. Thompson on?
He was on.
Is he muted?
Stephen Kroll was on, and
Esther Horowitz.
Esther Horowitz.
Okay.
Yes, Steve Kroll is here if Mr. Thompson is not available.
Okay. So go ahead.
My apologies, Mr. Cole, and if you'd like to go ahead, I appreciate you being on today.
It's our pleasure to be on here. And Kelly, are you able to give me the ability to put the slides up on the screen?
Are you able to share, present now?
I see you listed as presenter,
Yep,
and at this point.
go ahead and present now.
All right, I've hit present now.
I'll ask you to pull your file.
Okay, and here you go. Are we able to see the slides?
Not yet.
No?
Not yet.
All right, let's try again. I've hit the share button and it seems to not be sharing.
Did you pick your file? You have to choose your file and then share.
All right, Chrome wants you to share my screen.
There you go.
Okay,
Yep.
Here we go. You should see it now.
We do.
Okay, great. Thank you very much, Commissioner Gibson. My name is Stephen Kroll. I'm with UCM, joined by my colleague Esther Horowitz today. And it's our pleasure to spend a few minutes with you talking about digital healthcare and telemedicine. As Commissioner Gibson said, with Commissioner Gibson, EMS Coordinator Keeler, Chairperson Murrell, in the fall of 2019, none of us knew at that time just how important telemedicine would become to us for managing the COVID circumstance that we are still in. So we'd like to talk with you a little bit out today about what our capacity is, what our company does, and hope that there might be opportunities for strategic partnership between us and Columbia County. So we are in medical practice. We're based in Troy, New York, and our radius is all over. We have client states internationally, but the locus of our biggest concentration of business is our home state of New York State. Our goal is to give people the right care in the right place at the reduced cost. So what we have done through our business model, and this is about 6 years in this business, COVID having certainly injected a lot of energy into telemedicine. But for the last 6 years, we have been perfecting a pathway for patients to contact a medical provider by telemedicine to obtain a diagnosis, to receive treatment in place, and to be net care. All that can be done from their home or whatever location they're at. We've certainly been seeing a several 100% increase in the use of our service come March of 2020 when COVID was present in large numbers. It is something that is simple and fast for people to use. See a picture of the smartphone on the screen. We have an app that says Consult Now, and you press that app and you're talking to a care coordinator on our team who is able to connect you with a medical care provider, whether it be a physician's assistant, a nurse practitioner, or a physician, all being emergency trained. One of the most important pieces of use case is we are much less expensive than emergency room or urgent care. So we can treat many of the things that people today will go to the emergency room. They have a long wait at the emergency room. They have a big bill from the emergency room. They have to travel. We can do that with people that are in their homes. As you might imagine, this is tailored to COVID-19 concerns. Being the height of the COVID pandemic, people were asked to only come to the emergency room or go to their doctor's office if they absolutely needed it. And COVID has also really changed attitudes of people towards telehealth, and many people now are much more open to and may even prefer telehealth. We have contracts with MVP and CDPHP, so our service today is available to all insured patients of MVP and CDPHP, including their Medicaid managed care and their Medicare Advantage clients, and we're working with adding other payers as well. So what is the virtual emergency room? It's a one-click call for treatment or triage with an emergency medicine provider. You can reach us by telephone. You can reach us by video. You can reach us by telephone and send us a photo. You can schedule a consult using our app or from any internet-enabled device online. And our providers can do a number of things. Number one, they can provide you self-care instructions. So I guess the one example is somebody with a sprain. We can help somebody understand that a sprain does not require going to the hospital. You need rest, ice, compression, and elevation. So our providers can hear what's happening with an individual, give them instructions that will help them take care of themselves. We can call prescriptions into a person's pharmacy. So we do medication renewals for somebody who has run out of their pills, so they don't have to go to the doctor's office because they're out. A medication adjustment because their blood pressure medicine needs to be either given a little bit less, a little bit more, or call in prescriptions that are needed for an acute problem. We can send people for labs and x-rays and diagnostic testing, and we can make referrals to further care with scheduling assistance for people that need help. So our goal is for people that have non-emergent conditions, meaning they don't have a life-threatening condition, that means they need to be in the emergency room, is to get them in touch with our providers, and our providers and our care coordinator will provide them care and provide them navigation to where they need to go in the healthcare system without an expensive emergency room. And then we'll keep an eye on that patient. We check back with every patient several days after the encounter. So to look at the flow, we engage the patient, whether by phone or web or app. Our ER triage team will assess their health needs. We'll either be able to treat them definitively. So in the case of somebody that has a need for a medication, we'll prescribe that medication. And if there's need for further steps, we'll make those further steps with them. We'll send them for lab work. We'll send them for an x-ray. We'll get them an appointment with a specialist, and then we'll follow up and through the treatment for that episode of care. So there are a number of different ways that someone can work with us. Number one, we can be accessible for a local government workforce. So right now we're available to anybody that's insured through CDP, HP, and MVP. And the appeal of this to CDP, HP, and MVP is simple. We know that our charge is going to be a fraction of the charge to go to the emergency room for taking care of somebody's non-emergent healthcare needs. Our charge is a fraction of going to an urgent care center. So we can be accessible for a local government workforce, whether through a contract with a local government workforce or through people's membership in CDP, HP, and MVP. And we have hundreds of thousands of clients that are through either businesses or government that are simply enrolling their population in our service because they know that if we encourage people to use UCM, it will cost them less and they'll still get great quality care. So just an example of a client that's present in your community, Stewart Shops. Every single employee of Stewart Shops has UCM's emergency medicine triage through our virtual ER for their healthcare needs as an alternative to going to the emergency room. The second way to access us is something we've been working on with Commissioner Gibson. Commissioner Gibson generous enough to introduce us to his department heads at a meeting they held several months ago. And many of the people that are prospective patients that are on Medicare or on Medicaid receive lots of support from the county social services staff, from the county health staff, from other branches, the mental health, from other branches of the government in Columbia County. We're a new alternative for them for healthcare, and people will follow the lead that they're given by the professionals that are helping them, whether it's with their nutrition or whether it's with job training or whatever things that the county may be helping. We try and get the message out that this virtual ER is an available and covered service for so many Medicaid patients and so many Medicare patients with the two of the largest insurers in our region, so people can access us. The next thing that we've been talking with PJ Keeler about is we can also be available to your emergency crews. So for example, right now we work with the county government in Rensselaer County where people that call 911 for non-emergency conditions can be, if they went right into our virtual ER and treated by our virtual ER staff rather than have to go to the hospital. And we take that one step further as well, is an EMS crew can identify a patient on the scene and say, we know this person needs some health care, but they don't have an emergency. We can arrange them a virtual ER visit in their home with the EMS crew present on a telemedicine call and avoid the long trip to the hospital, taking an ambulance out of service that should be available for emergencies and getting them the right care in the right place at the right time. So we're using telehealth communications to bring the physician right to the patient in collaboration with that emergency medical technician or the 911 dispatcher. We'll look at a patient's level of severity, determine their next steps of care. After the diagnosis, we'll make a referral, we'll make a treatment. This cuts down on time-consuming and unnecessary ambulance use at a time when the EMS system is under stress. And we're blessed of having insurers in our region that understand that EMS agencies have needs for financial support, and they will pay the EMS agencies to help work with us to treat the patients at home, which is something that is not common in EMS. EMS generally is paid for transport, and that's a national issue because the emergency medical service system in our country was born out of the Department of Transportation when the interstate highway system was built. So we're still, as a nation, behind the times in getting our EMS providers paid for doing the things they do in the patient's home. They get paid for transport. Well, we're changing that paradigm, working with CDP and MDP that are willing to pay for the care with us, but also pay the ambulance services to work with us, supporting the patient in the home. So this diagram just shows you the architecture of how emergency medicine triage works. We sit above all the services that MVP and CDPHP make available. We can give people self-care resources. We can prescribe a medication for them that'll be delivered to their pharmacy right in their town. We can make an appointment, either make them a referral for lab testing, or we can make the appointment for them. Today, CDPHP and MVP for COVID testing. So people that have COVID-related concerns, they don't feel like they're sick enough to go to the hospital, they'll call us. We'll help them arrange their COVID testing. We can make an appointment with you for a primary care physician. So a lot of what we do is also resetting the time clock. Sometimes people will think at 10 o'clock or 11 o'clock at night that I'm sick, I need to go, I need to get help now. Well, most doctors' offices aren't open at 10 o'clock or 11 o'clock at night. So where do they go? They go to the emergency room, which is the place where the sickest people should go for minor things. So our physician can be on the phone with somebody 10 o'clock at night, provide them the self-care instructions, the reassurance that they're not critically ill, they can stay at home till morning, and then help them get an appointment with a primary care doctor or a specialist like an orthopedist in the morning. And we can always navigate people that really truly need ER care or urgent care. So we will not ask someone to stay in their home that doesn't belong there. A small percentage of our patients will present to us, and our physician is going, I know you called us for treatment at home. I think you belong in the emergency room. We need to get you there now. And they'll stay on until emergency transportation arrives. And then all the other services that a health plan can offer. So if a health plan has mental health services available, we'll navigate people into those mental health care services. So that's what we are and what we do. We have a 98% track record of ER avoidance if you get into working with us. We have 98% patient satisfaction. Every patient is given a patient satisfaction survey. We have about 60% utilization for our basic clients. That means if there are 1,000 people enrolled in our service by somebody, we'll get 600 consults for them in a year. And you can see there's some numbers of average saved. And we're able to take the cost of if a business sends us their data, we run their data for what the true claims are for sending somebody for a minor illness or sending someone with a more intense illness to the emergency room versus what it costs with us. And it's hundreds to thousands of dollars that can be saved per encounter, and that adds up. So it's been a pleasure to talk with you a few minutes today. I might end by saying there are several opportunities for Columbia County. Number one, the county workforce could use UCM as an alternative for their urgent healthcare needs. Number two, we've started working with Commissioner Gibson, and we hope to continue in having the county departments educate their constituents about what a marvelous opportunity this might be for them as a healthcare option. We're very interested in working with the ambulance services in Columbia County so that they will spend less time on calls that are not urgent, taking people to the hospital that don't need to be there. And lastly, we can work with your 911 dispatch center to divert low acuity patients directly to the virtual ER, preventing them from having to go ahead and use emergency services for small things. So that is our presentation for today. I'm going to pull off the stop sharing function. So I'm going to ask you if you have any questions that we can answer about what we do. And we look forward to working with folks in Columbia County.
Thank you very much, Steve. Does anybody have any questions?
Rob, I just want to add, telemedicine is certainly, it's up and coming. As we speak, I'm kind of working with our local county medical director, Dr. Stipa, our physician in charge of the ER here locally, and together with Dr. Daly, who's our regional medical director. I recognize fully that telemedicine is going to be an integral part of Columbia County's EMS system as we move forward. However, there are complications and there are issues that are associated with this. And I would just ask that I'd be allowed to work with Steve and a committee, maybe Bob Gibson and whomever else, to see if we can't work on some of these issues moving forward. And if we do this, we want to make sure that it's incorporated and it's done right versus having to step back. We do have some issues with payments to the EMS agencies themselves. And basically they would lose some call volume through this. And we have to work out a means that we can keep our agencies in Columbia County financially stable. So there are many issues associated with this. It's a great idea. There's no question about it. It's sadly needed. And but I do ask that you wait on this to see if we can't work out some method whereby all involved are not harmed.
Thank you, PJ. I'm sure there'll be much more extensive conversation before this was adopted. The only question I had, Stephen, was what is the average time when somebody calls, and how quickly does somebody, is somebody on the phone from the time somebody calls or uses the service? How quickly is that person get a response?
Our phone answering is within 30 seconds. Our average today was about 20 seconds. A person will be on the phone for care coordinator for roughly 5 minutes, and then we're going to route them in with a provider. We're able to, the actual time of the encounter runs from 10 to 15 minutes total. If somebody's doing it on video, it generally takes a little bit longer than doing it by phone. So it's up to 15 minutes for the full encounter, very much like a visit in the emergency room. You spend a couple minutes talking with the nurse, and then the physician walks in, and you're really only with the physician 5, 6, 7 minutes for that treatment. We guarantee our clients, if we do not have a provider available, that they'll get a call back within 15 minutes. So if you're called at a time when all our providers are talking to somebody, you get a call back pretty quickly. We check that metric every day, and we staff to it. So we add additional staff if our wait time to talk to the provider would get. In addition, when working with emergency medical services agencies, we guarantee them no wait time. They go right to the top of the queue. We have a special way that they enter into our system so they become the next patient, because we recognize in working with EMS systems that their time is valuable. We can't keep them sitting waiting for us. They'll receive prompt service. We'll get them in right away.
Thank you, Steve. Any other questions?
I have a question.
Go ahead, Linda.
In a county that's rural like ours and broadband has been not totally a success here, how does that affect your services?
We do work the short answer is, if somebody can get in touch with us, we can work with them. We can talk to you on a landline telephone. We can talk to you from a desktop computer with internet, that a cable modem in your home. We can talk to you via your cell phone, wandering around using your Wi-Fi. If you can get in touch with us, we can work with you. We do recognize that in working with EMS agencies, there is the complexity of whether the EMS agency has got Wi-Fi connectivity, but it is not a problem for an EMS agency to contact us on the landline phone from somebody's home. So we work with rural communities in figuring out how to make that connectivity. Wi-Fi being the best for video sharing, for picture sharing, but we make it work. And I guess to most directly answer, if someone doesn't have communication that supports talking with us, there may be some use cases in some places that just don't work. And obviously, as broadband grows, those will shrink.
Okay. Any other questions? Thank you, Steve. I appreciate the presentation. Bob, did you want to come back on?
Sure, I really didn't have anything to add, except, you know, these folks onto the chip. And to PJ's point, you know, I think everything has to be looked at. I think we want to do anything we can in our community and in a rural county like this to make sure access to healthcare is expedient and available for everyone. But you know, I agree that we just want to look at it very closely before we do anything.
May I make a note, please? I'm Esther Horowitz. I work with Steve. Mr. Keeler, if you are inclined, I'll reach out to you and we can set up a time to talk.
That would be fine. Steve has my number.
Fantastic.
Thank you.
Yeah, and you know, and PJ, to your specific concern, the insurance companies have been very generous in setting rates, realizing that we have to keep our EMS agencies whole.
Right.
So I'm just a little unclear, Rob, and can you explain, like, are we buying this?
To be honest with you, Linda, this is the first time it's been presented to me. So this was just, I think, for the committee to kind of get a sense of what's out there. And then we'll have a more extensive conversation if it's something we wanted to move forward on. So I'm kind of have exactly as much information as you do at this point. I don't know the costs. I don't know much more than what was presented to us. So if it is something, I'll chat with Bob about it and the chairman, and then make sure that our committee has a much more extensive conversation about it.
Thanks.
Well, I'll just interject. Yeah, I think that's exactly right. I think it's all of this is just at the threshold level here, and it's sort of an introduction to get to know it. And if there is any sort of sense on the board that they would like to look into this further, this gives them an opportunity to do that.
Thank you, Bob. Okay, Bob, do you have anything else for our committee?
I did. I have one resolution request to fill a senior account clerk position. It's been vacant for several months. Mindful of the freeze that we've had, but it's a position that I really do need to have filled. It's a critical part of the support collections unit. And what I told the chairman, and I believe that given the list that's out there, I can hire directly from within, therefore not bringing on a whole cost of a salary, but just promoting somebody from within. I will say if that were not the case, and if that does not turn out to be the case, I wouldn't fill the position otherwise.
This already went through committee?
It did yesterday.
Okay.
Yes. And the position where the person would be promoted from is not going to be filled. So it's a net negative in terms of being down a position.
Okay. Any other supervisors have any questions? If not, I'll entertain a motion.
I'll make
Make a motion.
Okay. Supervisor Meskin, second. Second.
Sterling.
Supervisor Sterling, second. All in favor?
Aye.
Opposed? So carried. Anything else, Bob?
Yeah, just one more thing, and I mentioned this to you, Supervisor Lagonia and Chairman Morrell this morning, but I wanted to just give it to the committee at large. in this morning. Did tell us they had just arrived from Florida. So we did all of the COVID questions, and we went a little more in depth as that is considered a hot spot by the governor. And we made arrangements to house this individual, but asked them to quarantine. And we are going about the business of making sure that all of their daily needs are met during the quarantine so they don't have to go out, including meals and things that have to get picked up from the store. Just want the committee tracking on that. We didn't have any kind of protocol in place until this came, so I wanted to bring it up, and I didn't know if the Director of Health, Director Mab, wanted me to add anything to that, but that's what I'm doing, and that's what I plan to do with any other folks that come and tell us that they are in the hotspot.
So my question, Bob, is this a staff person or is this a client?
No, this is a client who just came in this morning, said they had traveled up from Florida. They haven't been here in several years, but this was the area they were from, and they just happened to come back last night, and they came in this morning. So we said, well, whereabouts are you from? They gave the location in Florida. We asked the questions and whether or not they knew about any exposure. Did they feel any symptoms? They was negative to all of that. And we let them know that the governor has a list of places where he's asking people who come in to quarantine for a certain amount of time, that we would ask that be followed, that we understood if that created any hardship, that we would be able to provide food and any other necessities by direct delivery. And I guess my question for the board is there any other precautions that you would like us to take?
So the only thing I would ask is that you pass on this individual's name and contact information so that my nurses can, have their usual conversation with them. And because there's paperwork at the end of the quarantine period that they're given that basically says they're done. So I would want to run through the department.
Okay, I thought as much. So, Director Mab, I will get this particular information together for you and pass it on first thing tomorrow, and then I will make that part of the protocol should someone else arrive under similar circumstances.
Okay.
Are there any questions for Bob? Okay, thank you, Bob.
Thank you.
Human Services, Michael?
Can you hear me now?
Yes, we can. How are you?
Good afternoon. I'm doing well. Jack, I might as well let you know I've got somebody coming in from Florida to Albany Airport tomorrow. This is, I'll communicate with you the situation. It
Okay.
should not impact Bob. Knock wood.
This is a staff person or individual?
A client.
Okay.
Who went to Florida a couple of months ago against an AOT court order. It's a long story, but anyway. And we're following much the same protocol.
Michael, while we're on that, we discussed this, Jack, Matt, we had discussed the procedure when the governor first came out with this from these, he just added several more states, and it was fairly loosely rolled out. I think that's being kind. And now that he's become much more stringent on the protocols and procedures, have we received anything on that, Jack? Has anything changed as far as, because I knew there was no communication to your office as of maybe last week. Has it changed since he's come out with a much more stringent protocol?
Short answer is no. My email address is the email address that all of the information from the airports would go through, and I have yet to receive an email.
So I just wanted everybody to understand that there are all of these states that, whether they're flying in or they're coming here, they're supposed to be quarantining. And we talk about fines of $2,000, $5,000. Yet we don't really have much of a guideline given to us from the state. So although we would like to adhere to those rules and regulations, it's been, again, a little bit of a challenge in reference to this one. So I just wanted everybody to know that. So anyway, Michael, I apologize for interrupting you, but could you continue?
Problem. The two resolutions we have in front of you are both personnel resolutions. Both of them have started with emergency fills and have been vetted through the Point One committee yesterday. Both of them relate to backfilling budgeted vacant support positions. One is a clerk Kipis. That position was vacated May 22nd, and the other is an intake clerk vacated June 15th. These are two of the current 11 vacancies that our department has, and I am very grateful to the board for the opportunity to request authorization to backfill these vacancies, these critical support positions.
Are there any questions for Michael?
I'm sorry?
The only thing I'd like to say is that both of these positions are on the front end. So when clients come into the Office of Mental Health, these are the two of the first people they would meet. And they're critical in terms of intake. So it would be kind of hard for them to operate without someone there to greet the individual.
I'll make the motion. Mussman.
Second, Uri.
Yuri, all in favor?
Aye.
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 So carried.
I have
Any
another,
other questions?
I have another question for Michael.
Go ahead, Michael.
So I talked to the community college today about the mental health
I can
services.
barely hear you, Michael.
Okay, sorry. Can you hear me now?
Sort of.
Hello? Okay. I'll just try to talk loudly. So I talked to Columbia Green Community College today about the position that the college used to provide, or that the county used to provide to the college, where the college provided funding for the county to have mental health services hours at the college. And they're still interested in providing this funding if we have a person to do it. They said, I think it was $70 an hour at 350 hours for the year. And it's my understanding that we would pay our staff member less than that $70 an hour. So that would help cover some of the, some extra hours as well as the personnel costs beyond the salary. And I know that we're a lot of positions down, and maybe if this is, if we can add a position and partially fund it through this community college funding, that would help make that a viable position while providing, using the rest of the hours to serve the county.
We are down so many clinicians that we not only have a waiting list, but we have one of our current staff about to go out on maternity leave with a caseload of 80 that we have to redistribute to the existing clinicians. So unless we have an ability to unfreeze a clinical position that's been vacant for months, we would not be able to honor that contract, sadly, even though the contract would be supported by the payment from the college. So we would be eager to pursue that, but at this point, that request has not been honored. But we cannot do it with the resources that we have now.
Right. So could we, I guess, what do the numbers look like if we unfroze one of those positions, partially funded that unfrozen position with money from the college, and then that position could in large part just take care of this giant backlog that the county already has. And so I imagine there would also be some reimbursements. That.
And then we have an ethical dilemma of, do we take that position that's unfrozen and we hire somebody, do we use that exclusively for the college and sacrifice the people that have been waiting on the waiting list for months and the people that have been served by the individual who's going out on maternity leave and dropping their care. So I don't know what the right.
Well, I don't see why it's sacrificing to the college. The college wants to contract for a set number of hours, which would be less than full time. So I think the rest of the hours that aren't the college's hours.
It's a little over $24,000 what the college would pay. So that doesn't come close to paying for a full-time position.
Oh no, we had, I think, it was 350 hours a year. I think Dan Almasi's on the call. He can tell you how many days a week during the semesters we had people. I think we had staff there 2 days a week, 2 partial days a week. So it wasn't a full-time position.
Right, but my understanding is that we have a giant backlog of cases. So this would also be a way of addressing some of our backlog.
You're wrong. I'm not fighting, Supervisor Shimides. If it could be used to combine serving the college and offering services to people that have been waiting for months, I would be in complete support of it.
Well, the only thing I'll say is that we're in the process of hiring a new director. I would like to have the new director be part of that conversation.
And if I could, we're also in the process of working with the college on their budget. We're going to work on that some more in next month. And we have to see where everybody is on that. It's a good idea, but we have to see if the money's really going to be there.
I feel like these are essential workers here. Now, why are we denying? We've got so many people backed up for care here. I think it's almost criminal of us not to get more Michael for this. I mean,
well, I don't want to be accused of a crime. Can we pick this back up again once we have all the pieces in front of us, say for next month? That would be my request. I'm not saying no. I think we need to do a little bit more digging and make sure that we're doing everything that we can.
I think if Michael put together a proposal, Michael Cole and/or the new director, it would be something we could look at the personnel committee meeting. And Sarah, in answer to your question, we're still looking at a $10 to $15 million budget hole.
I know.
And we're under the mandate of having a balanced budget.
Well, we got lives at stake.
Yep.
Okay. I do want to just mention 2 things briefly. We got the anticipated news from our state agencies, Office of Mental Health, OASAS, about third quarter advance withholds, basically state aid cuts. As we anticipated, OMH is cutting 20% state aid. That will impact our county Department of Human Services budget. It will impact Twin County Mental Health Association and other OMH contract agencies. And we're working with them to plan those cuts. The cuts are come in the form of withholding a percentage of the third quarter advance for the time being, always with the caveat, unless the federal government comes through. But they're doing it a quarter at a time. For OASAS, for our substance use disorder agency, the cuts are 31% state aid cuts for the third quarter. So we're working with our 3 chemical dependency contract providers to determine where they will be making those cuts for the third quarter. We will not be getting the money in, so we're not going to be giving what is in the contract for the full amount for a quarterly advance. It doesn't contract that. I don't contract, and I'll defer to Ron whether or not I need to redo the budget. But this obviously impacts our continuum, the service continuum, at least temporarily. It's hard to imagine a scenario where this is not going to continue in subsequent quarters, but it remains to be seen. And just one last thing, last meeting, I believe you approved a resolution for a transfer of assets and liabilities from Philmont Hearth to the Mental Health Association and related contract changes necessary. I will not be executing, I will not need that resolution because the date has been delayed of that event until January 1st, 2021.
Okay.
Thank you.
Thank you.
Any other questions for Michael?
Mr. Chairman, Matt Morrell here, just in answer to Sarah too, as we look at the forecast and the revenues, Sarah, as they come in, it doesn't mean that our position may not change depending on if things do improve. So I want to put that caveat out there. I mean, we are looking at it closely. Right now, unfortunately, as PJ had said, their projections are right on, which is, it's good that their projections are right on, but it's bad that their projections are right on. So.
Well, let's hope. All right. Thank you, Michael.
You're welcome.
Jack?
Okay. I have a single resolution before you, authorization to initiate a contract with Mental Health Association to pay for an epidemiologist / technical assistance coordinator through the Healing Community Study. As you may recall, we are. It's hard to find ourselves shifting gears and talking about anything but COVID, but we are one of 8 counties in the state and the first wave in the Healing Community Study. The chairman and I just signed off on year 2. They have been patient for the last couple of months because of COVID, but now they're basically gearing up and wanting us to fill out our staffing. We have had a full-time project manager, and we were working with Greene County on a half-time epidemiologist. What the expectation on the folks at Columbia University is that we would have a full-time project manager, a full-time community engagement facilitator, and they would love this if we had a full-time epidemiologist and a full-time technical assistance coordinator. But in smaller counties like ours, they're accepting us merging those 2 positions. What has happened is that the epidemiologist who was working with both counties is now going to work exclusively with us. Greene County is going to go and obtain their own epidemiologist and add the duties of technical assistance to that as we are. So we're taking over the whole contract for the epidemiologist. We have, under the grant, we have $357,000 to pay for the positions that we're expected to fill. So this will bring us up into the 200 and some odd $1,000. I'm going to come back to you next month, hopefully, with a community engagement facilitator. We will probably, at this point, based on the numbers, run about 327,000 out of the 357, and whatever we don't spend on salaries, we can use what they call impact dollars, which would essentially go to pay for programs in the community. So that's what I'm looking for, us to take over the full-time position epidemiologist, who will become a half-time epidemiologist and a half-time technical assistant coordinator under the grant.
Any questions for Jack? Not, I'll entertain a motion to approve.
Motion.
I'll second it.
Second, Gary, all in favor?
Aye.
Aye.
So carried. Okay.
I did send along our director's report. If you look at it, you can see that this is going to make for an interesting, really, literally, the whole department has been dedicated to COVID up until this point. Now they have begun to, the state health department has begun to expect us to resume our usual food service inspections, water system inspections. Early intervention is gearing up for the fall. Hopefully, some school starting and whatever. So it's making for interesting times because some of my folks, and especially in environmental, have been doing yeoman's work helping out with the COVID response. So we're going to get busier than we have been, which is hard to believe. But I don't know if there's any questions that you might have under the director's report. I'll be glad to answer them.
Any questions from anyone?
I have a question about the number.
Supervisor Berry, go ahead.
Last month I asked if there was a way to explain how the numbers for particular towns have changed. In Germantown, it went from being reported consistently at 8, and all of a sudden we were down to a 1. And I'm getting questions about that, and people are asking about the efficacy of the reporting in total. Did you get an opportunity to look into that for us?
I did talk to Victoria, who generates that report, and she showed me, and then since you asked the question, I went back to the zip codes and the various addresses and whatever, and she was just working to refine the numbers around where people lived, and that's pretty much what happened. It was people who were living in addresses that weren't Germantown, weren't within the town.
Right. Some of them could be Livingston, some of them could be Claremont.
Yeah.
Right. So that is the difference.
Yeah, that's the difference on that.
Okay. Thank you.
Any other questions?
Yeah, I have a question for Jack.
Go ahead.
Hudson we have a lot of people coming and going in Hudson, and there's been how to know what the reality of is. Are people, how to justify or make clear what in reality is happening in Hudson proper in terms of numbers. It's very difficult to figure out where we are because our zip code is mixed in with Greenport, et cetera. I mean, that's
I think
it's confusing.
As with Supervisor Berry's question, Victoria, who's not originally from Columbia County, but has working very hard on that report to try to move the Greenport addresses out of Hudson and even Stockport addresses out of Hudson, so that it's a more accurate reflection of what's going on in the city. And I will tell you, the interesting thing is we did report last week. I think we talked about a little spike, and it's hard to see a spike in the numbers because it's not a very big one. But it was all in the Kinderhook area, and it wasn't necessarily. Hudson's been fairly quiet when it comes to number of cases.
Okay, that's great. It's great to know. Sorry there, Kinderhook.
Yeah, me too. Trust me.
You're having some trouble up there.
Kinderhook's up for sale. I'm giving it for $1.
Well, we can't really ever forget the fact that area is, as it's always been the case. A lot of people who work at nursing homes, Barnwell in particular, live in that area. It's just convenient by, and so I think it is connected. It's really not much of a spike. It was interesting for a while there, like for a week, every single positive we were getting was in that area. Even though it was like 6 or 7 positives, it wasn't that much, but it was in that area.
Well, Jack, around the same time, we had a spike in the Hudson Greenport area too, based on a community spread.
Based on community spread. And that we look at as true community spread, even though somebody could work at Barnwell and live in Greenport. But, with us opening up and Memorial Day and whatever, we did get a little bit. But you have to be pleased with the numbers, for Columbia County. I think people are doing the right thing by social distancing and my experience at going out and about Walmart and whatever is everybody's wearing a mask. So I think we're doing the right thing.
Thanks, Jack.
There was that I don't know what it was. It was a little treatise on contact tracing that I got a couple of 3 weeks ago, and I did respond to that. And I sent that to Mr. Lagonia. Did all the supervisors get that? My response to that?
I distributed it to everyone. Yes. So that letter was received, and Supervisor Mussman asked me to put it on our committee. I do know that I asked Jack if he would just talk about it at our committee, but he already responded to it in a letter form. So I don't know if there's more questions. I think he answered most of the questions, but if there are more, please feel free to ask. Jack's here to answer those questions.
I think the one thing I would respond is that, you know, in terms of the information and the state, if you can imagine, the state of New York would, if it really wanted people's personal information, would just get hammered by, millions and millions of pages of data and whatever like that. They don't ask for it. They're looking for just the bulk numbers. They don't even want to know necessarily where they're located town wise or anything else like that. And that information isn't shared. It's kept, it's kept in a file cabinet here. We're still doing things by paper, and so it's not shared. And the contact tracing, as I know you all know, talking to the choir, contact tracing is just a tool that we've used in public health for decades. And I think it's valuable to have our nurses doing the contact tracing. They know the community. Very often they know, the interconnectedness between people and families and whatever. And we've kept it local, and I think we're going to be able to keep it local.
Thank you very much, Jack. Before I ask for public comments, Jess Nabozny's on, and we haven't had her at any committee meetings. I'm not so sure anybody has any questions, but if you did, she's available. Are there any questions for her, Youth Services?
I actually wanted to say a couple things if I could.
Absolutely.
I know we have 4 of the 5 City of Hudson supervisors on. I just wanted to say, I think it's so great. You should be so proud of your City of Hudson Youth Department because they are running summer programs for the youth. They are monitoring. I met with Commissioner Gibson briefly today in regard to some transportation. They are going to need some transportation to some of the sites where they are offering the programs. So Vanessa, the Director of Recreation, is going to kind of monitor and evaluate this week where she thinks there's going to be some gaps with youth not getting to the sites. And Commissioner Gibson has offered to help with that. And I've kind of been the in-between with that. And I helped them iron out some wrinkles with that. So we're going to work on that this week and then maybe start some transportation. I know Commissioner Gibson has to work on a contract and hopefully we can get that worked out. But the City of Hudson has done a really great job in separating the programs into different areas, keeping it very small groups with the youth and making sure that they're going to be able to do their distancing. Transportation may be a little bit of an issue, but I think it's going to work out. And the beach looks really nice with all of the umbrellas being separated. They've done a really nice job. They've worked really hard, and I give kudos to them.
Thank you. Are there any questions for Jessica? Are there any other comments or anything else anybody wants to bring up?
And I also just wanted everybody to know that New York State Office of Children and Family Services has not provided any youth development programming. I don't know if we're going to get any. I've been on all the conference calls with OCFS as well as the Association of New York State Youth Bureaus. And, they keep trying to be optimistic, but we'll see.
Any other comments? Any comments from the public? If not, I'll entertain a motion to adjourn.
I'll make it. Yuri.
Yuri, second. Morel, all in favor?
Aye.
Aye.
Thank you, everybody.
Thank you.
Thank you.
Good night, everybody.
Right.
Thanks for coming.